Okay, let's jump right into this explainer on developmental dysplasia of the hip, or DDH as we'll call it. Now, for any medical student out there, this is an absolutely core topic in pediatric orthopedics, so let's get straight to the essentials, shall we? So, first things first, what exactly is DDH? It's really important to get this straight. DDH isn't just one single condition. Think of it more like a spectrum. On one end, you might just have some simple hip instability. On the other, you've got a complete dislocation and some pretty severe deformities. And understanding this range is absolutely crucial because it's going to dictate our entire diagnostic game plan. Okay, so what's causing this? Well, there's no single culprit. The etiology is what we call multifactorial. You've got genetic factors in the mix, like a congenitally shallow acetabulum. Basically, the hip socket isn't deep enough from the get-go. Then there are hormonal factors. Think about maternal estrogen and relaxin, which can make an infant's ligaments extra lax. And finally, you have mechanical factors. We're talking about things like a breech position in the womb, or even certain ways of handling the baby after birth, like using papoose sports. Right, so all these factors together, they trigger this cascade of pathological changes. It's like a domino effect. The acetabulum, that hip socket, starts to get deformed and shallow, which means it can't give the femoral head the coverage it needs. At the same time, the top of the femur develops excessive anteversion and valgocity. And the end result of all this, you've got a really lax joint capsule that just can't keep the hip stable. So that leads us right into the diagnostic pathway. And here's the thing. The absolute key to a good outcome with DDH is catching it early. And to do that, we rely on a really structured screening system called the triple sieve.
The triple sieve is, without a doubt, a cornerstone of infant care. It's not optional. It's a series of 3 mandatory, standardized orthopedic exams at really key moments. First, in the maternity ward, right after birth. Then at the 6-week follow-up, and one more time at the 4-month checkup. This systematic approach is truly our best defense against letting a case slip through the cracks.
Now, during these exams, there are 2 absolute cornerstone clinical tests you have to know, the Ortolani and the Barlow maneuvers. You can think of them as functional opposites. The Ortolani test is all about trying to reduce an already dislocated hip. You're looking for that telltale clunk as the femoral head slips back into the socket. On the flip side, the Barlow test is about assessing instability. Here, you're gently trying to dislocate the hip. A positive test tells you that hip is unstable and dislocatable. So it's not just about those 2 maneuvers. Clinicians are also on the lookout for other physical signs. For instance, there's the galeasis sign. This is where one knee looks lower than the other when the baby's lying on their back with their hips flexed. It's a big clue for thigh shortening. You also need to check for things like asymmetrical skin grooves on the thighs, or if there's a noticeable restriction when you try to abduct the hip. All of these are huge red flags. All right, so let's say you've done the exam and you have a clinical suspicion. What's next? How do we go from, I think something's wrong, to a definitive diagnosis? Because look, the physical exam is absolutely essential, but it's not the final word. We need to actually see what's going on inside that hip joint. And that's where imaging comes in. To confirm things, we need pictures. In very early infancy, before the top of the femur has turned to bone, sonography, ultrasound, is our go-to tool. We use it to measure the alpha and beta angles for what's called the graph classification. But then, after about 4 months, that little ball of bone, the ossific nucleus, becomes visible. At that point, we switch over to x-rays. Arthrography, that's usually reserved for when we're planning for surgery. So with these images in hand, we can now classify the severity of the dysplasia. We grade it. Is it a grade 1 unstable hip, a grade 2 subluxed hip, or a grade 3 fully dislocated hip? And look, this classification isn't just some academic exercise. It's incredibly practical because it directly tells us what our management strategy is going to be. Which, of course, brings us to treatment. Now, if there is one single guiding principle in managing DDH, it's this: timeliness is everything. I mean it. Early and effective intervention is absolutely critical. And this idea is so important it even has a name. It's the Merck-Janssen rule. And the principle couldn't be simpler. The sooner you can get that hip reduced in a stable, concentric way, the better the prognosis is going to be in the long run. It just underscores how critical timing is. Seriously, every single week counts. So when it comes to treatment, you can pretty much divide it into 2 main pathways. And the path we take depends on the severity and the child's age. For the less severe cases that we catch early, we're going with conservative management first. This usually means a close reduction using some kind of abduction brace. But if that doesn't work, or if we're dealing with a late diagnosis or a really severe dislocation, well then surgical intervention is what's on the table.
All right, so let's dig into these intervention strategies a little deeper. We'll start with a closer look at the conservative options first.
Okay, when you think conservative treatment for DDH, you should immediately think of the Pavlik harness. This thing is the absolute workhorse. The whole goal is to hold the baby's hip in a specific position, flexion and abduction, so the femoral head stays snug in the socket. This position actually stimulates the hip to develop normally. But, and this is a huge but, you have to be so careful with its application. There's this safe zone for the angles of flexion and abduction. If you have too little abduction, it just won't work. But if you have too much, you risk cutting off the blood supply to the femoral head, and that can lead to the really devastating complication of avascular necrosis. So what happens if the harness just doesn't work? Why would a closed reduction fail? Well, it's often because there's something physically blocking the way. We're talking about specific anatomical obstacles. It could be a really tight iliopsoas tendon that's just pulling the femoral head right out of the socket. Or it could be soft tissue, like a hypertrophied transverse ligament or an inverted labrum that's literally getting in the way, blocking the head from seating properly. And when you have those kinds of obstacles, or if conservative treatment has failed for other reasons, surgery becomes the next step. Surgical interventions really fall into three main buckets. First, you have open reduction, where the surgeon goes in, clears out whatever is blocking the joint, and physically places the femoral head back in the socket. Then you have femoral osteotomies. These are procedures that actually reshape the femur to correct its alignment. And finally, you have pelvic osteotomies, things like the Salter or Pemberton procedures, which are all about reorienting or reshaping the acetabulum itself to give that femoral head better coverage. So this all brings us to one final, and I think really crucial question. We have effective treatments, right? We have conservative options, we have surgical options. The principles are crystal clear. The benefits of intervening early are undeniable. So what's the single biggest barrier to a successful outcome in DDH? It's not the complexity of the surgery. It's not the design of the Pavlik harness. The biggest barrier is a missed or delayed diagnosis. In the end, it all comes back to that systematic, vigilant application of the triple sieve. Because with DDH, you are literally in a race against the clock.